In order to provide optimal care for pregnant patients, we need to know what happens in different stages of pregnancy in terms of physiological changes. In order to assess their breathing rate, for example, we need to know what's normal at the different stages. A pregnancy is divided into 3 phases. The first trimester, the first part of the pregnancy, the second trimester, the middle part of the pregnancy, and the third trimester, the end of the pregnancy. Now we're going to have a look at what happens in each stage. Okay, so we're now going to introduce different physiological variables. One fun thing you could do now is try to think ahead of me. So when I'm writing a physiological variable here, try to make up in your mind if the variable is unchanged or if it's increased or decreased in this particular phase. So first up, we're going to have a look at heart rate or pulse. So the heart rate is slightly increased in the first trimester, also slightly increased in the second trimester, and greatly increased in the third trimester. The second thing we're going to look at is blood pressure. So the blood pressure is slightly decreased in the first trimester, it's greatly decreased in the second trimester, and relatively unchanged in the third trimester compared to non-pregnant patients. The change in blood pressure is mainly due to a change in systemic vascular resistance, SVR. In simple terms, SVR is the diameter of the blood vessels, meaning that when the diameter of the blood vessels increase, the systemic vascular resistance decreases. Everything else being equal, so does the blood pressure. So there is a decrease in SVR in the first trimester, a large decrease in the second trimester, and relatively unchanged SVR compared to non-pregnant patients in the third trimester. So when you look at the cardiac output, how much blood does the heart pump out each minute? It's slightly increased in the first trimester and then greatly increased in the second and third trimester. This also corresponds well with the fact that there is an increased blood volume. Obviously, the fetus and the placenta and so on need a sufficient blood supply, so there is a marked increase in total blood volume. So blood volume is somewhat increased in the first trimester and then greatly decreased in the second and third trimester. Whereas the stroke volume of the heart, how much the heart pumps with each beat, is slightly increased in the first trimester, greatly increased in the second trimester, and somewhat increased in the third trimester. And at the very end of the third trimester, it's relatively unchanged compared to non-pregnant patients. This, of course, varies somewhat. So the reason for many of these physiological circulatory changes are, of course, hormones. For example, progesterone leads to smooth muscle relaxation, and when the smooth muscles of the blood vessels relax, the systemic vascular resistance decreases. Now we're going to look at some of the respiratory changes. So let's start out with the respiratory rate. And everyone thinks the respiratory rate is increased, then in fact it's relatively unchanged throughout pregnancy compared to non-pregnant patients. Of course, I'm not talking about women in active labor. However, if you have a pregnant patient that has an elevated respiratory rate, please do not blame the pregnancy, as the cause is usually something else. But we know that pregnant women have a decreased level of arterial CO2. PaCO2 is slightly decreased in the first trimester and then greatly decreased in the second and third trimesters. So how can this be when the respiratory rate is unchanged? It of course has to do with tidal volumes. Tidal volumes are slightly increased in the first trimester, also in the second, and then greatly increased in the third trimester. And to some that might seem a bit strange when you have the large pregnant uterus putting pressure up on the lungs. How could the tidal volumes then be bigger? But trust me, they are. However, the ability to increase the tidal volume, if there is an increased demand, is severely limited by the fact that the pregnant uterus is putting pressure on the lungs, especially in the third trimester, meaning that parameters such as functional residual capacity, or FRC, goes from being relatively unchanged in the first trimester to being decreased in the second and then significantly decreased in the third. So the functional residual capacity is how much air is left in the lungs after a normal expiration. When pre-oxygenating a patient before intubating them, we want the FRC to be as large as possible. The larger the FRC, the bigger the reservoir of oxygen, which means that when the patient gets apnea or stops breathing, the oxygen in the lung can keep on diffusing over to the blood and giving us a longer, safe apnea time. However, when the FRC is greatly reduced, as in the later stages of pregnancy, you have a shorter time until desaturation. So what happens with the oxygenation? If you look at the PaO2, that is the amount of dissolved oxygen in the blood, you see an increase in the first, second, and third trimester. If you look at the oxygen saturation, the saturation of hemoglobin, you look at the SaO2 if it's measured on a blood gas, or SpO2 if it's measured on a pulse oximeter. There really is no change compared to pre-pregnant levels. We're now going to have a look at some of the hematological changes that happens in pregnancy. So starting out with hemoglobin itself, it is slightly decreased in the first trimester, greatly decreased in the second, and then slightly in the third. When we look at overall coagulation, that is not measured in some kind of blood sample, just the overall tendency of the blood to coagulate. You see a slight increase in the first trimester, a slight increase in the second, and a great increase in the third. Having a ramped up coagulation system means that women are somewhat protected from postpartum hemorrhage, that is bleeding after birth. When we look at the white blood cells, they are slightly increased in the first, the second, and then greatly increased in the third trimester. When we look at the platelets, they're relatively unchanged in the first and then decreased in the second and third trimester. Some of the explanation for the decrease in platelets and other hematological parameters can be hemodilation. When the blood volume expands and increases, it tends to dilute the platelets and red blood cells. So if production is not ramped up equally as the increase in blood volume, you get a decrease in platelets and so on. The increased coagulation system may also use up some platelets. So let's look at some of the renal changes that occurs during pregnancy. When we look at glomerular filtration, we see that the GFR is increased in the first trimester and then greatly increased in the second and third trimester. This has a lot to do with the increase in blood volume and cardiac output. More blood is pumped throughout the body, meaning that also more blood is getting to the kidneys and getting filtrated. The creatinine will do the opposite, being decreased in the first and then greatly decreased in the second and third trimesters. So the creatinine level is obviously not the same as renal function. Muscle mass and so on also contributes, but everything else being equal, when the GFR increases, the creatinine will decrease, leading to this pattern here. So you might be wondering what is happening to the temperature, and the fact is that you see a slight increase in the first trimester and then relatively unchanged body temperatures in the second and third trimesters. So the body weight is typically increased in the first and then greatly increased in the second and third trimesters. And obviously, the typical weight gain during pregnancy is not just the fetus, but also the placenta, amniotic fluid, increased blood volume, and so on. And because the albumin level, that is an important protein in the blood, also tends to decrease in pregnancy, pregnant women has a greater tendency to have edema, that is fluid buildup in the tissues. And this increased fluid buildup, of course, also has its own weight. However, if there is a significant and rapid increase in body weight and a rapid increase in peripheral edema, one must always consider if there can be some kind of pathology lying behind it. For instance, preeclampsia. So the next thing I've done for you is that I've prepared this video coming up on the screen right now. Click it to continue the journey with us.